reduced urine output, body swelling. No history of skin rash, arthritis, hemoptysis, no family history of renal disease. So after we evaluated the patient, we found that he had blood 3+ and protein 2+ in urine. His initial creatinine was 249 and had a urea of 26. He had an HB of 9.6, platelets 425. Serum protein was 65. We couldn't do an albumin. We didn't have reagents. We did an infectious screen. So hepatitis B, surface antigens, RPR were negative. Autoimmune screen, C3, C4 were normal, ANA negative. We just received the anchor result. That's also negative. And then on ultrasound, corticomedullary differentiation was preserved. There was increased echogenicity. The kidneys were of normal size. So our working diagnosis was acute glomerulonephritis, probably post-strep. But during the clinical course of the patient, we noticed that instead of the patient improving, the edema was worsening. The serum albumin started dropping. The first albumin was 23, and by last week, we had a serum albumin of 16. In addition, patient also developed pleural effusions and needed tapping to reduce respiratory distress. We also did an echo, which gave us a normal ejection fraction of 65%. The serum creatinine was also worsening. So because of this picture, we wondered whether the patient could have crescentic glomerulonephritis and immediately started him on high-dose methylprednisolone and have continued with prednisolone at 2 milligrams per kg. We also did a biopsy and sent that to pathology. So we can hear from Dr. Mumba what they found.
So sorry about that. So we received one core of kidney tissue, and it's presented in the slide there. Most of what you see in that slide is basically the cortex, which at higher magnification shows a couple of glomeruli. And can you see my cursor?
Yes.
Yes. So demonstrates a couple of glomeruli. That's one glomeruli, that's the second one, that's a third one, a fourth one, a fifth one, sixth one, seventh one. So a group of glomeruli. The number of glomeruli were 14, which I deemed to be adequate for assessment of the tissue. Then these glomeruli, basically, this is a PAS stain. So we did 3 stains. We did an H&D stain, a PAS stain, and a Mason trichrome stain. We attempted to do a silver stain, but it's work in progress, something that we need to improve on. It didn't come out well. So we hope we can try and improve it in the next couple of weeks. So this is a PAS stain showing you one of the glomeruli. And you notice that this glomerulus kind of looks hypercellular. A lot of these cells basically represented by nuclear features. But also you notice that at the periphery here, you see cells which are basically abutting the basement membrane, the outer basement membrane of the glomerulus. So same thing over here. Then I'm sure you can't appreciate this, but trust me, here you see basically a shrunken glomerular tuft. So going further, I think this is much more clearer. This is an H&D stain, and the H&D stain shows you a glomerulus. Okay, within this glomerulus, you see capillaries. Okay, relatively nicely open capillary loops. But within this, you also see an increase in cellularity over here with some neutrophils. Then you also see a lesion over here. Okay, kind of segmental lesion. Initially, when I saw this, I was convinced that we're probably dealing with FSGS. But then again, went further and did a Mason trichrome stain, and it did not highlight any sclerosis occurring in that lesion. So this is another lesion basically showing you a hypercellular glomerulus over here, kind of open loop. Then the same picture as before, where you get this lesion over here, kind of extending almost to the outer perimeter of the glomerulus, and very cellular over here. So it kind of gives you a picture like it's an FSGS, but I thought this is basically proliferating cells within the Bowman's space. Then this picture over here. So I know it's difficult to appreciate on H&D, but this is a glomerulus, okay? And within this glomerulus, you notice that there are a lot of cells, okay, some of them being neutrophils. Then you do not see the open capillary loops, okay? So it's basically a very hypercellular glomerulus with neutrophils, with basically closed capillary loops. Then over here, you also see a tubule, and within this tubule, you see acute inflammatory cells, which are basically your neutrophils. Then going further, this is a glomerulus, okay? This is the outer rim of the glomerulus, very nice thin basement membrane on the outside, okay? Then there seems to be also a chronic inflammatory infiltrate within the interstitium. But you see this glomerulus over here, kind of shrunken glomerulus, very compressed. Then you get this, which is basically your crescent, a bit cellular on the outside, but it seems to have picked up a bit of fibrosis over here. So this is basically a crescent which has both features, the cellular features and fibrotic component to it. So it's basically a crescent in evolution. So this is now with a PAS10, which just highlights the collapsed glomerulus, which has been pushed by this crescent, which has also accumulated a bit of fibrosis. But you can see that there's this cellular component over here, and that's basically the limiting basement membrane of this glomerulus. And you notice that this is the area where you get your Bowman space, and within this Bowman space, there are these cells, okay? Sorry, I overloaded this slide with a lot of, the presentation with a lot of slides so that you just have an appreciation of what I'm talking about. So this is another glomerulus over here, which shows you an area, okay, which looks a bit more sclerosed, which is basically towards the end before it becomes a globally sclerosed glomerulus. But also with this one, there's some remnant of these cells in the outer rim just before the outside of the glomerulus. So this is basically in the Bowman space, and you see this cellular, these cells with quite a lot of cytoplasm around them. So same thing here, okay? This is probably quite bad, but you can see that there's a bit of basement membrane over here, okay? And that's basically your whole glomerulus. Then in the center here is your collapsed capillary tract. Then on the outside here, you see a bit of you see a bit of this cellular accumulation with a bit of fibrosis, okay, and compression of basically your tuft of cells. Going further, this is now cut at an oblique angle, and what it shows you is basically part of the glomerulus, just showing you those so-called epithelial cells that have parietal epithelial cells that have proliferated. So this is basically part of what you would see in a glomerulus, making up those cellular crescents. So kind of similar here, over here, this is a glomerulus, sorry, okay, over here. Then you see that there is a tuft over here with closed capillary loops, kind of cellular in nature. Then on the outside, okay, you can see this is the limiting basement membrane, but you see these cells on the outside, okay, making basically this crescent, which is a cellular crescent, okay. Then here you see basically open capillary loops over here, okay, here they seem closed, but you get these cells with a bit of fibrosis being laid down over here. So this is basically a fibrous and cellular crescent forming in the glomerulus. Sorry, going further. So the same thing here, this is a glomerulus. Okay, sorry about the picture, not the best, but this highlights nicely your outer limiting basement membrane. Okay, and within the Bowman space, you get these cells which are proliferating. Okay. Going further, I put this in here just to demonstrate an H&G of a glomerulus. You don't see the open loops, very cellular, a lot of acute inflammatory cells within the glomerulus with basically closing up of the capillary loops. Then on the outside here, you see, though limited, that's the basement membrane on the outside, but you see these cells which look a bit more fibroblastic, a bit laying down of fibrous tissue as well, that crescent. Then this just highlights a glomerulus that has undergone basically total sclerosis with intervening chronic inflammatory cells within the interstitium, with some level of atrophy within the interstitium because there are gaps where we don't see any tubules. Then this basically was our Mason trichrome. Remember, we'll say Mason trichrome is a good stain because it highlights fibrosis. So very good in highlighting either those sclerotic crescents or FSGS. Okay, so here you see a basically well-preserved glomerulus. Not the best in terms of thickness because this may deceive you into thinking that there's a bit more mesangium, okay, and a bit more increase in cells, but this is a very thick slide, not the best to comment on. But of interest for me was this glomerulus over here. So this part here basically shows you some fibrinoid necrosis. This pink material is indicative of that. Then on the outside here, you see a whole bunch of cells, okay, going around this collapsed glomerular area or tuft area. Better still here, so this is the area of the glomerulus, okay? Then here you get the cells proliferating within the Bowman space. And the outer limit of this glomerulus is over here. So same thing with this one here. You see that this is the glomerulus, then the outer limit is over there, and these are basically the cells proliferating within the Bowman space. So this is also highlighting the same thing, an area of the glomerulus, okay? A bit of that fibrinoid necrosis that we see. Then there are these cells here which are basically proliferating within the Bowman space. So here highlighted is the same thing, but here you have a tuft of capillaries. But these here, the blue, or is it the green, highlights areas of fibrosis within this crescent. So this is basically a crescent that's progressing towards a more fibrotic picture. Then I put in this just to highlight one thing that we also saw. Within the stroma, the tubular interstitium, you get these tubules, okay, with this architecture simplification we call, okay, with a mitotic figure basically showing you that there was some damage to these tubules and they are basically healing post-injury. And of course, you can see that within the interstitium, there's some level of an acute and chronic inflammatory infiltrate. Okay, so there's one slide that, sorry, I didn't put in. There's one tubule that showed basically a lot of acute inflammatory cells within that tubule. So the question I had was that, did we culture the urine or did we look at the urine to check for, just to rule out a pyelonephritis? So given the history that I received and given the picture that I have, the conclusion I came up with was this was a crescentic glomerulonephritis. Fortunately enough, most of the crescents are of the cellular type. Okay, there was only one that showed some level of fibrosis occurring within that crescent. So I counted 8 glomerulus that demonstrated a crescent out of the 14, and our cutoff point in calling it crescentic is 50% of glomeruli showing that picture. So my final conclusion, irrespective of the initial primary glomerular lesion, was a crescentic glomerulonephritis. But because of that increase in hypercellularity within the glomerulus, those neutrophils, the obliteration of the capillary loops, and the clinical presentation initially, the only thing I could come up with that fits into that picture that the person probably had before ending up with a crescentic glomerulonephritis was a post-infectious glomerulonephritis. So the only other question I had is, did we do an ASOT level in this patient? So that's where I end. Any questions?
Thank you very much. In answer to your question, we didn't have enough money to do an ASOT. So we thought we'd get more information by doing C3, C4, ANCA, and NA, which were negative. Yeah. And then we didn't do any culture of the urine. However, at some point, the patient did seem to have some kind of sepsis, and we gave antibiotics.
Okay. right.
Yeah, but that was way after the presentation of the patient.
For the patient. Okay.
Yes.
Yeah, I noticed that the C3 and C4 were within normal limits. So I noticed that a bit of my reading up, they tend to talk about it normalizing when the condition has been there for a bit and has undergone some level of treatment. And especially that it was evolving into a more crescentic picture, they tend to normalize, so to say.
Usually by about, if it's post-strep, usually by about 8 weeks.
8 weeks.
But yes, then but from literature they say that in terms of having a low C3,
Yeah.
only about 90% of patients will have a low C3 by the time that they are presenting. So
That's-
yeah, the pictures that you've shown us really like are suggestive of a proliferative thing, so like post-infectious. So yes, it fits
yeah.
in with the picture that we saw in the patient.
Yeah. I mean, the only
Yeah.
other differential diagnosis is membrane proliferative because it's also proliferative, but you don't see the areas where we see capillary loops, you don't see that thickening of the capillary loops. Then you also
Okay.
don't see that mesangial expansion and hypercellularity. So for me,
Okay.
I lean towards more post-infectious.
Okay.
Yeah.
Guys, anyone with a question? Anybody with a question?
Not
Okay,
for
so
me. Very clear.
thanks. Okay. Thank you once again. So at least now we are justified in having given the high dose steroids in the sense that we have fibrocellular crescents. So now we'll
Yeah.
give the patient 1 dose of IV cyclophosphamide,
Okay.
and hopefully that will help. But the creatinine has, after the methylprednisolone has come down, the latest one is I think 150.
Okay.
So
That's nice.
that it's nice to know that we were dealing with fibrocellular
Yeah.
crescents.
Yeah.
And then in terms of the list for the requirements for immunofluorescence stroke